It's an honor to be here with you and discussing all of the aspects of prevention, screening, treatment, and surveillance for gynecologic cancers. Gynecologic cancers often don't get as much of the big clout as the other cancers do, especially breast cancer, which is Breast Cancer Awareness Month is coming up very soon. And so raising awareness for gynecologic cancers is very, very important, and honored to be here. The first half of my talk will be focused mainly on modifiable risk factors, and then we can get into the specific prevention and screening for the specific cancer sites. So when we think about risk factors for all cancers, we divide them into modifiable, non-modifiable ones. The non-modifiable ones are things that we're born with, or things that we can't control, such as our age, our genetics, gender, ethnicity, and race. So I won't focus on that for now, but I'll spend the majority of the first half of this talk discussing the primary modifiable risk factors, because those are things that we can all be improving and changing to decrease our risk of cancer. I'm sure we've all heard the statistics on obesity in our country. This is a graphic from the CDC site, which shows that the rates of obesity among both adults and children are slowly increasing. The top blue line is the adults. Bottom line is the youth, children. In the US, about a third of adults are obese. According to worldwide trends, our country happens to be worse. By 2025, about 20% of all adults will be obese. Those are very startling statistics. In 1975, only 105 million were reported to be obese. In 2014, 641 million people were reported to be obese. So the numbers are startling and are increasing. So obesity is calculated by body mass index, which takes into account both our height and our weight. Obesity is defined as a BMI, or body mass index, greater than 30. This map shows the percentage of adults who are obese per state. The darker color, red, is the higher rate of obesity. In the South, the rates of obesity are largely between 30 and 40%. In New York and New Jersey, tri-state area, we're doing better. Our rates of obesity are about between 25 and 30%. The effects of obesity span pretty widely. There are several medical problems that are directly linked to obesity, such as high blood pressure or hypertension, high cholesterol, diabetes, heart disease, stroke, gallbladder disease, arthritis. And the main reason we're talking about this today is because there are certain cancers that are linked to obesity. In the gynecologic realm, obesity is directly related to endometrial or uterine cancer. It's also linked to breast, colon, kidney, gallbladder, and liver cancer. I would also be remiss not to mention that the treatment for any of these cancers is also riskier in patients who are obese. So not only does obesity can cause certain kind of cancers, it can also cause the cause the treatment to be much more risky. So in this table, you can see that the estimated annual healthcare cost of obesity-related illness. The bottom line is the U.S. In one estimate, the United States spent about 190 billion, or nearly 21% of annual medical spending, on obesity-related costs. When you compare this to a country pretty close by, like Canada, which is the third line, you see that only less than 3% of their total costs in healthcare were spent on obesity-related costs. Not only this, but there are several indirect costs related to obesity. It is estimated that the annual nationwide productive cost of obesity-related absenteeism, or not showing up to work, from is between 3.38 billion to 6.38 billion dollars, or $132 per obese individual. There are also social and emotional effects of obesity, including discrimination, lower wages, lower quality of life. And it's been calculated that obese patients cost 42% more in healthcare annually compared to the normal weight individual. So when talking about obesity, the next logical step is to talk about diet and exercise. This is another graphic from the CDC website that just goes over the recommended physical activity needed. They recommend 2 hours and 30 minutes or 150 minutes a week of moderate intensity aerobic activity. Moderate intensity means you can talk during it, or an hour and 15 minutes of intense, high intensity aerobic activity. In addition to, or some combination of both. And in addition, they want you to do muscle strengthening activities at least twice a week. That would be working any combination of major muscle groups. So, are we getting enough exercise? The answer, which you probably could have guessed, is no. The percentage of adults aged 18 and over who met the physical activity annual guidelines for aerobic physical activity was 53.1%. That's actually higher than I would have guessed. But the amount of adults who were getting both the recommended amount of physical activity for aerobic and muscle strengthening was only 23.5%. And again, that varies by state, and the states that are less physically active tend to also be the states with higher rates of obesity. So you might recognize this food pyramid on the right as, you know, the old, that's what we used to think was balanced diet in the old days, but choosemyplate.gov has a different way to think about eating. You want to have more of a balance. You want the majority of your diet to come from vegetables. So there's dark greens, red and orange greens, legumes, starchy vegetables, and other vegetables. You also want to incorporate fruits, especially whole fruits. Next is grains. And you want to make sure that at least half of those are whole grains. You also need a healthy, a small amount of lean proteins, and you want to incorporate a small amount of dairy. For, you don't need to, but that's something you want to consider in terms of balance. There's always fad diets and, trending diets such as keto, which cuts out a lot of carbs, or paleo. And it's really up to you to decide what healthy diet you want to follow. But ultimately, it's about how many calories you consume and then how many calories you expend with exercise. The average caloric intake for a man is about 2,500 calories. For a woman, it's 2,000 calories. On average, an American eats about 3,600 calories a day. So much more than we're supposed to. Next, we'll move on to tobacco. So tobacco use remains the single largest cause of preventable death and disease in the United States to date. Cigarette smoking kills more than 480,000 Americans every year. 10% of those deaths are related to secondhand smoke. Smoking-related illnesses in the US cost about $300 billion annually. And that's included nearly $170 billion in direct medical care for smoking-related issues. And 15% of US adults are cigarette smokers. So this one is another important thing to remember. The National Toxicology Program of the United States Department of Health and Human Services lists alcohol as a known human carcinogen, meaning it causes cancer. There's an increased risk in head and neck cancers, esophageal cancer, liver cancer, and breast cancer, as well as colorectal cancer. The reason we believe this is because alcohol can increase hormone levels, decrease absorption of certain vitamins, and break down into free radicals, which can cause inflammation and cell mutations and cell damage. This one, this slide, I was tempted not to include this one because we are in a global pandemic and stress is kind of the name of the game lately. But stress does decrease the immune systems. These figures are from a site called stressinamerica.org. It's a website that is launched and run by the American Psychological Association. There's a lot of science that supports that chronic stress decreases your immune system and thus your disease fighting capabilities. In the top left figure, you can see that stress levels are decreasing as the years progress, but we're still much higher than the desired level of stress, which is the blue line below. So orange is what we're actually having in terms of stress, and blue is what we would like. In the bottom left graph here, you see that it also differs by gender. So women are more likely to have stress than men. Again, the stress levels are decreasing, but the gap between those stress levels for women and men is widening. So what we do know is that chronic stress is more worrisome than acute stress, and that it affects your body's ability to fight disease, and it also causes more inflammation. The last bullet point here is important. Chronic stress may lead to decreased cancer screening. So if you're stressed, you might not go see the doctor, you might not be doing your routine medical checkups and whatnot. So now let's get into the prevention and screening by gynecologic disease site. So when we think about gynecologic cancers, the fallopian tube and the ovary are considered, in general, we consider that ovarian cancer. So when I talk about ovarian cancer, I'm talking about fallopian tube cancer as well. And then one category is uterine cancer and endometrial cancer. The endometrium is the lining of the uterus, and we consider those together. Then we have cervical cancer, which is the opening to the uterus or the womb, which we also consider vaginal cancer as part of that for the sake of this talk. And then the last category is vulvar cancer. The vulva is the outside, the external female genitalia. So first, let's talk about endometrial cancer. This is the most common gynecologic cancer in the United States. Every year, there's over 60,000 new endometrial cancer cases. And the death, there's about 12 to 13,000 deaths from endometrial cancer every year in our country. In fact, endometrial cancer is the only gynecologic cancer that has increasing incidence and mortality. And the reason for this is that the majority of endometrial cancers are directly related to obesity. And as the rates of obesity in our country continue to go up, we're going to continue to see increased endometrial cancer. So obesity, what it does is it causes an imbalance in the healthy hormone levels, increase in estrogen compared to other hormone levels. So any other thing that might cause an increase in estrogen level can also cause endometrial cancer. Some of those things are getting your period for the first time very early, late menopause, infertility, some breast cancer drugs such as tamoxifen, hormone replacement therapy can also increase the risk of endometrial cancer. Age is an important risk factor, so advancing age increases your risk of endometrial cancer. There are certain family histories or genetic predispositions, mutations that might put you at risk for endometrial cancer. There are no reliable screening methods for endometrial cancer. So there's no way we can test every woman or rule out endometrial cancer in women every year. We don't routinely perform sonograms or tests for endometrial cancer. But fortunately, endometrial cancer does present with symptoms in about 90% of early cases. So the main symptom that you might see is irregular menstrual bleeding. And that can be a warning that you could have something wrong. Another big issue is any bleeding in a postmenopausal person is something that needs to be brought up to your doctor and really monitored. Other symptoms can be abdominal bloating if persistent, changes in urination, or changes in bowel movements if persistent. And the way we evaluate any of these symptoms would be with pelvic ultrasound, and possibly a biopsy of the lining of the uterus, an endometrial biopsy, which for the most part can be done in the doctor's office. So prevention of endometrial cancer is largely centered around decreasing obesity, making sure your hormones are in balance in that way. So physical activity, weight loss, exercise, being closely monitored. If you're taking tamoxifen or hormone replacement, those are things that you want to be discussing with your doctor and doing routinely. Next, we're going to move on to cervical cancer, and we need to discuss HPV as, it's a main star here when it comes to cervical cancer. It is known that human papillomavirus, or HPV, is the causal agent of the overwhelming majority of a lot of cervical cancer. It is a sexually transmitted disease. There are several strands. So the low risk strands are strands 6 and 11. Those are associated with cervical warts. The high risk strands are the ones that can cause abnormalities of the cervix or cervical cancer are 16, 18, 31, 33, as well as several others. Most patients will have been exposed to HPV very early on in their sexual lives. Most have been exposed to HPV by early 20s. A little bit over 50% of women will have been exposed to HPV by 21, and about 70% of women will have been exposed to HPV by age 31. While over 90-ish% of HPV infections will be cleared or kind of made dormant by your own immune system, some may linger, and those can cause cervical cancer if left untreated for a very long time. There are other risk factors that can also put you at risk for cervical cancer. Most of them are related to your exposure to HPV, such as early onset of sexual activity, multiple sexual partners, a history of other sexually transmitted infections, early age at first childbirth. And these are three very important points. So anything that decreases your immune system, such as an HIV infection, certain medication use, chronic steroid use, that can put you at risk for cervical cancer. And then cigarette smoking can also decrease your immune system. And cigarette smoking and HPV kind of go, they work together to cause abnormalities on the cervix. So I know on the last slide, we spoke about women get exposed to HPV, the majority very early, younger than 31 years old. And so that might be a frightening thing to hear, but the time from exposure to HPV to cervical cancer can take up to 20 years. And in that time, your body can clear the HPV infection or make it go dormant so that it's not causing any issues. So the normal course of HPV is that, you are exposed, it can cause some issues. The issues can then regress or progress, and that would be something that would be picked up on a pap smear. And then if left untreated for 10, 20 years, that's when it becomes a cancer. So in recent years, we've kind of changed the way that we screen for cervical cancer with pap tests. So no matter when you started having sex, we start pap smears at age 21. For women who are between age 21 and 29, we do what's called cytology only, meaning we just test for abnormal cells. We don't test for HPV for the most part in that age group. Then in women who are 30 to 65, we test for both HPV and abnormal cells. And we do that every 3 to 5 years. If there's testing that's ever abnormal, then sometimes you might fall into a group that gets tested more commonly. One of the things that's newer over the past few years is that we don't test people who are older than 65 unless their previous screenings had been abnormal. So if you're 65 years old and have never had an abnormal pap or had not had an abnormal pap in the past 20 years, you don't need further pap testing. If you've had a hysterectomy for something that wasn't related to a cervical abnormality, so if you had a hysterectomy for fibroids, say, you do not need further pap testing. So in terms of prevention, one of the big things that we advocate for is the Gardasil vaccine, which is the HPV vaccine. It prevents against 9 different strains of HPV, all of the high risk strains. It has been shown scientifically to reduce the risk of cervical cancer in several countries. So this vaccine does translate into a reduction in risk of cervical cancer. So while most HPV infections do occur very early on, because there are still people who can get infected later in life, the HPV vaccine was actually recently expanded for approval use in women up to 45 years old. But ideally, you want people vaccinated before their first HPV exposure. So in preteens, adolescents. And if you have the vaccine, you still need to get pap testing routinely. This is, shameless plug for the HPV vaccine. This is another CDC graphic. It reiterates most of what I just said, but it's a great reminder. It really does work in preventing HPV infections, and it really works at preventing subsequent formation of cervical cancer. And so when it comes to discussing cervical cancer, we really need to stress this vaccine as part of that. The risk factors for vulvar cancer are very similar to cervical cancer. The risk factors are HPV, again, tobacco use, lichen sclerosis. Lichen sclerosis is a skin condition that can occur on the vulva that can increase your risk of vulvar cancer. A concomitant cervical cancer or history of cervical cancer can also put you at risk or increase your risk of vulvar cancer. Again, increasing age or immunocompromised states or any medications that would compromise your immune system are also risk for vulvar cancer. The most common symptoms of vulvar cancer are itching. Itching, abnormal bleeding, discomfort on the vulva. This picture here shows, visible lesion or mass on the vulva. We want people to be kind of aware of their bodies, know when things are happening that are abnormal or not typical for themselves. And so we want to kind of encourage you to just listen to your body. There are really 2 categories of vulvar cancer, the ones that are HPV related and the ones that are non-HPV related. The HPV related ones tend to affect younger women, and the non-HPV related ones tend to affect older women who have the skin conditions that we like vulvar skin conditions. So again, there are no reliable screening tests for this type of cancer. We recommend annual gynecologic exams, If there's symptomatic areas, you can get a biopsy. You would want to do monitoring of any symptoms, and smoking cessation. You really should not be smoking, because, like I said before, HPV and smoking go hand in hand to cause problems. This is just an example of a tool you might use for a biopsy, because biopsy obviously dictates what comes next. So when it comes to ovarian cancer, the main risk factors are anything that might increase the amount of times you will ovulate in your lifetime. Examples of this might be menopause or never having children, a family history of ovarian cancer, or a family or personal history of breast cancer are also risk factors. There are certain genetic mutations such as a BRCA1 or 2 mutation, which you may have heard of in the news. I know Angelina Jolie made BRCA mutations very, in the public eye a few years ago. Increasing age and endometriosis are also risk factors for ovarian cancer, and obesity. There are a few protective factors, such as using oral contraceptive pills, having your tubes tied, and increasing the number of children. Unfortunately, ovarian cancer rarely presents with any symptoms until it's advanced. Not only that, the symptoms of ovarian cancer tend to overlap with a lot of other gastrointestinal issues. In 50% of patients, they may present with abdominal discomfort and bloating. A lot of times, these things aren't really worked up or looked into because abdominal discomfort and bloating is pretty common. And so, again, you want to be very in touch with your body. If you're having abdominal pain that's getting worse or persistent and not really being worked up, you want to advocate to have your doctor look into these things. Another thing is you want to really know your family history. You want to ask on both sides of the family if anyone's had any kinds of cancers. You want to make sure your doctor is aware of your entire family history, because there's things they may not even realize might be concerning for a family, a genetic issue in your family that can cause cancer. So again, there is no reliable or effective screening tool for ovarian cancer. The way we want you to go see your gynecologist every year for an exam. Again, monitor for symptoms. You want to make sure you're advocating for yourself, letting your doctor know if anything has changed, such as new bloating, weight gain, your belly's getting bigger, you're feeling full after eating, small meals. And for women with a genetic predisposition, such as a BRCA mutation, we do ultrasounds and blood tests every 6 months. That, even in that population, it has not been shown to decrease the incidence of ovarian cancer. And so when it comes to ovarian cancer, it's really about listening to your body and seeing your doctor yearly. So in summary, you want to make healthy lifestyle choices, for weight loss and diet. You can use a lot of, there's a lot of new apps and exercise apps and calorie tracking apps. You want to recruit a family member to help you make healthy lifestyle choices. Talk to your doctor about bariatric surgery. Depending on your BMI, you may be a candidate for bariatric surgery. There's tons of tobacco smoking cessation programs. Bring it up with your doctor. There's medications, there's counseling, there's hypnotherapy. Those have been shown to work. Monitor your alcohol. Drinking is another way to possibly reduce your risk of cancer. Reduce stress. That's a lot easier said than done. Meditation, counseling, exercise also reduces stress. And then, in terms of each specific cancer, for endometrial cancer, weight loss is key. For cervical cancer, get your pap screens, don't smoke. For ovarian cancer, know your family history and monitor. And then for vulvar cancer, treat any skin conditions, don't smoke, and get your exams annually. So that is the end of my portion of the talk. Do you guys have any questions? If not, we can plan to discuss questions at the end of Dr. Lightfoot's lecture as well.
Thank you, Dr. Gerber. That was a wonderful lecture and so informative. We really appreciate you being here with us tonight and presenting. And yes, we will have time for questions at the end. So if anyone has a question, you're going to see a Q&A box on the bottom of your screen. So feel free to type it in and we'll take questions at the end. And with that being said, I'm going to turn the program over to Dr. Lightfoot. Dr. Gerber, I think you have to stop sharing your screen and then Dr. Lightfoot will be able to bring her slides up.
Are you able to see my screen now?
Yep, that looks great. Can you just bring it up full screen? Perfect.
Okay. So thank you, and thank you for all that information, Dr. Gerber. I share your enthusiasm for being here and a dedication to increasing awareness about the GYN cancers. I'm going to focus a little more on how these cancers are treated and a little bit about follow-up. So nothing to disclose. So Dr. Gerber talked a lot about symptoms and how we diagnose these. I'll review some of those, and then the majority of my talk is the overview of how these are treated. I'll talk a little bit about follow-up. So she had reviewed, GYN oncologists treat cancers of the reproductive tract depending on where you're treated. Some practices, you have a single provider that does systemic treatments and surgery. That's what GYN oncologists typically do, which is different than many other types of cancer where you have a separate surgeon and a medical oncologist who does the therapies. And in some practices for GYN cancers, those are split, but generally speaking, it is the same provider. There are lots of different ways we can treat cancer, and those include surgery, radiation therapy, chemotherapy, what we call molecularly targeted therapies. So these are medications that have a very specific target, and then immunotherapy, and we'll talk a little bit more about that. And so any combination of these could be used to treat your specific cancer, and it depends on a lot of different factors that your doctor would take into account in terms of what sequence of treatment or which of these, but not everybody needs all of these types of treatment for their cancer. And then the last element of cancer treatment in general that's very important is clinical trials. So these are sometimes, new agents or new combinations, but that might play a role in somebody's cancer treatment anywhere along the line. So surgery is an important part of cancer therapy. Sometimes it is the first thing your doctor would recommend and how we assign your stage of surgery. Sometimes that's all some women need, so you might only get surgery. Sometimes we time surgery after somebody's received chemotherapy. And for some cancers, you might not receive chemotherapy or surgery at all. And so I'll highlight some of those differences. In terms of radiation, so we don't give radiation ourselves. We would refer to a radiation oncologist as another team member that actually gives the radiation, but we work with them very closely. Radiation in general is better for controlling disease that's in one area. So if you think about, surgery is usually to remove disease or make sure there's not cancer hiding somewhere. Radiation is if you knew it was in an area and you want to target that area. So in the little figure here at the top, if you had a garden and you knew you had some weeds mixed in with your flowers and you wanted to just kill the weeds, then you could, target those. But there is maybe some rays that transfer to the normal flowers. And so there are side effects to radiation that are related to that. But in general, it's good for one targeted area. For our cancers, we use what's called external radiation and internal radiation, or brachytherapy. So external radiation, you have usually a CAT scan or some type of imaging, and then they design the radiation program that you would get, and you get positioned on one of these beds in a very specific way. And then the machine delivers radiation from the outside. So this is called external beam radiation. We also use a special type of internal radiation called brachytherapy. So this is just one example of what the applicator might look like, but there are lots of others. This is typically placed in the vagina. Either this picture shows a woman that still has a uterus, but sometimes we're giving this type of radiation after surgery so that you may not have a uterus. And then this applicator gets hooked up to the machine that gives the radiation. We also use chemotherapy. So chemotherapy in general is a type of medication given to directly kill cancer cells. There are many different types of chemotherapies that might be recommended depending on the type of cancer you have, and the side effects also vary depending on which type of chemotherapy your doctor might have recommended. Chemotherapy is not always needed to treat cancer, so there are many women who have cancers that we treat that will never need chemotherapy. And then, as I mentioned, we sometimes use it before or after surgery. If we use it before, that's the neoadjuvant chemotherapy. And then it's also used for recurrence in cancer. The chemotherapies that we give for GYN cancers most often are given through an IV, or if women prefer, they can get a port placed and it can be given through there. Sometimes, because it's hard to get an IV, women will have a port. And then there are other less common ways we give chemotherapy, like through a port that's inserted directly into the abdomen. Targeted treatments and immunotherapy. So this is just to say that these are treatments that don't necessarily kill the cancer cells directly, but might work on other pathways. And we know that cancers are, very tricky, and they have a lot of different ways that they support themselves. And so sometimes that's through growing their own blood vessels. And so some targeted therapies work directly on blood vessels. And as we're learning more, we're finding more and more targets so that we can find more specific drugs for each person's type of cancer. So you might, when you meet with your doctor, depending on the type of cancer you have, we sometimes look for certain changes or mutations that we know to happen in that type of cancer, and they might recommend some of these targeted therapies. Immunotherapy is also a very quickly growing field. And so there are different types of immunotherapy. They're not all the same, but in general, these treatments are using your body's immune system to, you're basically getting your own immune system to attack cancer cells. And some of the types of medications we use here, basically what cancer cells do, you can see here on the left, is the tumor cells, which are these big yellow diagrams, have an interaction with the immune cells that basically tricks them into thinking that they're normal. And so it's your body's way of, the cancer's way of tricking your body into not recognizing that it's even there. And so the immunotherapies that we give can disrupt that interaction so that the immune system can then say, gosh, now I see this cancer, it's not normal, I will go after it. And so I think of it as, it's sort of like the immunotherapy removes the cape that the cancer cells were hiding under so that it can then attack the cancer cells. Clinical trials. So as I mentioned, your doctor might talk to you about a clinical trial anywhere along your treatment continuum. So it could be as early as, right after you get diagnosed, it could be including surgery or radiation or chemotherapy, a targeted agent, immunotherapy. And there are different phases of trials. So earlier trials are the phase 1 and phase 2 trials. And so these tend to be smaller studies where we're still learning about, whatever the combination of drugs is or the new treatment is. And those phases of studies are basically telling us, the safest dose with the least amount of side effects. And we get some information about how well that treatment might work in your type of cancer. Phase 3 trials are bigger studies, so include more patients. And this is usually when we've already kind of found a medication that we think has a lot of promise or a combination, and are now expanding that to more women. And typically these studies have what you would get as treatment if you weren't on clinical trial versus a new combination or novel therapy. And so clinical trials, you might hear about a lot, and this is really an opportunity to get, the next best, the treatment that could be our new standard of care once we've studied it. And so this is a very important part of cancer treatment. So in terms of specific types of cancer and how we treat those. So Dr. Gerber already highlighted this. So, for uterine cancer, some people say, well, I get a pap test, why didn't it catch my endometrial cancer? And that's because pap tests are really for the cervical cancer. And as she mentioned, these aren't done yearly, but we still recommend at least annual follow-up with your provider so that they can check in about any abnormal symptoms. Abnormal bleeding or postmenopausal bleeding is the hallmark symptom of uterine cancer. And then just to highlight, there are different subtypes of uterine cancer. So the most common type is the one that develops in the lining of the uterus here. And then sarcomas are rare, but those develop more in the body of the uterus. And these are treated somewhat differently. So in terms of endometrial cancer treatment, for women who want fertility sparing treatment, so they're younger, haven't yet had kids, for certain subtypes, not all endometrial cancers are eligible for this, but for the most common subtypes, we can sometimes treat these with hormones. And commonly what that means is that we put a hormonal IUD that has progesterone in it into the uterus, and then sometimes add oral hormones as well, depending on the response to treatment. And then once we clear the precancer or the cancer cells, then a woman can go on to try for pregnancy and then get follow-up for definitive treatment of her cancer later. For most women with endometrial cancer, they would have non-fertility sparing treatment. So this typically involves a surgery to assign your stage of cancer. And for endometrial cancer specifically, minimally invasive, meaning small incision surgery, is preferred. And this can be done either robotically, and that's what I showed here on the right, where we have special robotic system where your surgeon's still doing the surgery, but there's it's the robot arms that are attached to the ports, or this could be traditional laparoscopy where the surgeon's standing right at the bedside. There's also been a move toward what we call sentinel lymph nodes, where the doctor would inject a dye into the cervix and see where it maps. For most women undergoing surgery, we would be doing a total hysterectomy, so the uterus and cervix, and removing both tubes and ovaries, and then assessing these sentinel lymph nodes, which are the first draining lymph nodes from the uterus. Sarcomas are a little bit different. And so for these cancers, the important thing to know is that we can't diagnose them in the same way by an endometrial biopsy, because sometimes we can, but oftentimes these are a little more challenging because they don't start on this lining. And as Dr. Gerber talked about, an endometrial biopsy goes through the cervix and is sampling just this part, not the wall of the uterus. So surgery for this rare type of cancer is very important. And the goal of the surgery really is to remove the uterus and anything that seems abnormal. And if a sarcoma is suspected, then the uterus or tumor should not be cut up in pieces or morcellated unless contained. And that's important for this type of cancer. In terms of treatments after you've been diagnosed with a uterine cancer, it could be just radiation. It could just be that brachytherapy or the local radiation. It could be the external beam radiation. And then for some women with uterine cancers that are at higher risk of recurrence, we sometimes recommend chemotherapy or even a combination of both of those. For ovarian cancer, some people say, well, there's a blood test that screens. We've already established that we don't have a great way of screening. And this just shows you that CA-125 is the blood test, the tumor marker that is most commonly checked when there's a concern for ovarian cancer. And this just shows you all the other health conditions that could make that number high that aren't because of ovarian cancer. And so it's not uncommon that that number, especially in a premenopausal woman, is falsely elevated, not because of cancer. We do, however, use CA-125 for women who get a diagnosis of ovarian cancer and who had an elevated CA-125 when they were diagnosed, because then we can use it to monitor response to therapy. If you had another tumor marker check that was high at diagnosis, your doctor might also follow that. And then just to emphasize that symptoms tend to be vague, so we have not yet found a good way to screen for this. For ovarian cancer, surgery and chemotherapy are really the backbone of treatment. Depending on your age and the type of cancer suspected from your tumor markers and how everything looks on imaging, some women are eligible for what we call fertility sparing surgery, where some of the reproductive organs can be left in place. But again, that would be determined based on the type of cancer and your age. Oftentimes surgery for the most common type of ovarian cancer means a big incision surgery, so an up and down incision and removing all reproductive organs, and then anything that looks abnormal. And if there isn't a lot of stuff that looks abnormal, we also remove what's called the omentum, the fat pad that covers the intestines, and lymph nodes. Chemotherapy is also very important in the treatment of ovarian cancer, and there are some different combinations of chemotherapy that might be recommended depending on the type of tumor you have. And then in general, radiation is used less commonly in the treatment of ovarian cancer, but sometimes might be recommended. In terms of cervical and vulvar cancers, we talked a little bit about HPV already. So some people say, well, it's only high-risk people, or I don't need the vaccine or the test, or my body, I was told my body clears it all up on its own. But as Dr. Gerber mentioned, it's very common. So about 80% of people in their lifetime will have been exposed or had HPV at some point. And yes, most people clear it, but if it persists, it can lead to precancers and cancer. So that screening and follow-up with your doctor is very important. And if you have a weakened immune system for the reasons she mentioned, so chronic steroid use or HIV infection, or being on immunosuppressants for a transplant, you might be at higher risk of your body not clearing it. HPV contributes to most cervical cancers, and I'd say cervical cancer is probably one of the trickiest things in terms of which way we treat it, and it's very individualized. It's like treatment of really all of our cancers, but in this case, for cervical cancer, surgery is not always indicated. So your doctor would do an exam and help decide based on if they think the cancer is spread or the size of the tumor. If you had a biopsy, like a cold knife cone, they would take into all the factors that they have from that to decide if surgery is really the right option. Unlike endometrial cancer, where we say small incision surgery is usually the right thing, for cervical cancer, this has actually changed some in recent years. And for the most part, your doctor would recommend an open surgery, which could be this a cross incision down low or an up and down incision. And they may recommend what's called a radical hysterectomy, where instead of just removing the uterus, sometimes the tubes and ovaries, They might say, well, gosh, we need to remove this extra tissue alongside the uterus because that's a place that the cervical cancers can grow out to. So they might recommend a radical hysterectomy. If your doctor determines that surgery is the right answer and you have surgery, there's still a chance you would need radiation or a combination of a low-dose chemotherapy with radiation after surgery. Sometimes we say we don't think surgery is the right answer and we can cure this cancer with a combination of chemotherapy and radiation. So that might be what your doctor recommends. And that's usually a combination of the external radiation I mentioned and the brachytherapy with a low dose chemotherapy given alongside the radiation to help the radiation work better. Occasionally we do find that this is a cancer that's spread, and so occasionally a woman might just get chemotherapy. Vulvar cancers, she mentioned any changes that you're concerned about, you should take to your doctor and get biopsied. Vulvar cancer oftentimes is treated first with surgery where we remove the area that's determined to be abnormal or that biopsy confirms has a precancer or cancer. And then we assess the lymph nodes. And in this cancer, the lymph nodes that we assess are the ones in the groin because that's the place that this is most likely to spread. For most women with an early vulvar cancer, surgery might be the only treatment you need. Occasionally, though, we do have to recommend chemoradiation if we find it in the lymph nodes, for example, or sometimes to even shrink a tumor that's on the vulva to make it more likely that we could remove it with surgery. And similar to cervical cancer, if we found that it's already spread to another site, like the lymph nodes up near your collarbone or the lungs, your doctor might recommend chemotherapy alone, or at least to start. For follow-up for cancer, so it's important to know that even if you've had a hysterectomy or your reproductive organs removed, follow-up is still important, and that's because other types of cancers can develop over time. If you have had a prior hysterectomy, it is important to know the type. So did they leave the tubes and ovaries? Did they leave the cervix? And that can help your doctor decide what type of screening tests you still need. And then for women who have had a GYN cancer, typically for most of the cancers we treat, the highest risk timeframe for when those would come back is the first 5 years after you were treated. So you'd have earlier follow-ups. Instead of annual visits, your doctor is likely to recommend follow-up anywhere in the 2 to 6 month range. And then you get graduated basically at 2 years and then 5 years. Now, there are some cancers that require longer term follow-up with your oncologist, and your doctor would talk to you about those scenarios. And then the one other, I'll just emphasize again the importance of genetics. So we know that there are some syndromes that can increase women's risk of the cancers we treat. And so understanding who had cancer and where that cancer had originated is important to help decide if you need genetic testing. It's also increasingly becoming part of what, how we decide on other therapies. So some women with certain mutations in their tumor or with a BRCA mutation or Lynch syndrome mutation might respond better to certain therapies like immunotherapies, for example. So that's important to understand and share with your doctor. In conclusion, we know that cancers can start in all parts of the reproductive tract, and there are different risk factors for each of those. We treat each of them very differently, and it depends not only on the type of cancer you have, but stage of cancer, sort of each individual's priorities or other health problems that you might have. And so that decision should really be made as part of a discussion with your oncologist so that they can take all of that into consideration. And then just another plug for a few good sources of information on the internet, including Foundation for Women's Cancer. SGO is our governing body, so the Society of Gynecologic Oncology. And the Mayo Clinic has a lot of good patient-friendly resources. Google is good for some things, but also has a lot of others. You can find whatever you wanted to find on Google. So these are some other good resources. And that is all I have. So I'm happy to take questions.
Thank you, Dr. Lightfoot. That was great. We do have a few questions here before we wrap up. Let's see here. First question, whether or not cancer runs in a woman's family, if a woman is in her 80s, is a yearly GYN exam necessary?
I can take this one. So there are, like we had mentioned, there's certain things that we don't do, such as a pap smear or a mammogram would not be recommended for someone who's in her 80s. But even if we're not doing any specific testing, a routine gynecologic exam, a checkup is still indicated, depending on, mobility, if the woman's able to get to the doctor comfortably. We still recommend a yearly exam.
Okay, another question here. I had a partial hysterectomy where only my cervix was removed. I still have my ovaries. Am I still at risk for the cancer as mentioned?
Yeah, so they only, typically with the hysterectomy, it means the uterus is definitely removed as well. But if they left the ovaries, or even if they took the ovaries out, as Dr. Gerber had mentioned, the cancers that start on the lining of the abdomen, called the peritoneum, can develop even if a woman's had her tubes and ovaries removed. It's less likely, but there's always that chance, even if we remove tubes and ovaries, that a cancer could develop in the cells on the lining of the abdomen, and that looks exactly the same as an ovarian cancer. And so the short answer is yes.
Okay, and it looks like those are all the questions we have. So with that being said, Dr. Lightfoot, Dr. Gerber, we thank you so much for being here tonight. Both of your lectures were so informative. And thank you to everyone who tuned in virtually. And that's all for tonight. So we'll see you next time and have a great night.
All right, take care.
Thank you. Bye.
Bye.